Okay, I believe we're live now.
Okay, maybe I can't see anything.
I see it.
Yeah! Yay! Finally.
I can't see anything here.
Hi, everyone. Thank you so much for joining us this afternoon, taking time out of your busy quarantine afternoon to spend time with us as we talk about the impact of COVID-19 on Black and Brown people, specifically Black people. Unfortunately, we had technical issues, as is the case always with technology. And we still having technical issues because I can't seem to see my Zoom, but we'll get it sorted out in no time. We have a backup. Um, I'd like to start off by saying that I'd like to thank everyone, especially the panelists, for being here today and taking time out of their busy schedules to join us. I know that everyone is busy, especially now with everything going on. For my colleagues who are now writing grants and also taking part in clinical trials and also doing some much needed research and taking care of individuals. As we may or may not know, Black and Brown people are most disproportionately affected by COVID-19. In New York City, we are 28% of the total population, but make up 28% of the total COVID-19 deaths. A recent analysis by the Washington Post comparing COVID-19 cases in Black majority in counties versus white majority counties found that Black majority counties were 3 times more likely to have cases of COVID-19 and 6 times more likely to have deaths related to COVID-19. If that was not enough, an analysis by the CDC also showed that out of the 580, or I believe 508 hospitalized patients, 48% were white, 43% Black, and 28% Hispanic, despite 55% of the population being white, 18% of the population being Black, and 14% of the entire population being Hispanic. So these figures are showing us that while the number of infection rates that we have is significantly higher than the number of people that we have in the community. And there are so many reasons for that we'll not be getting into right now. Today, all we'll be getting into is how does this pandemic, how it's affecting us, what it's doing to the health of Black people in the community. I'll start by listing my esteemed colleagues who's here to join us today. We have Dr. Alison Myers, who is an endocrinologist, and she's specializing in diabetes care. So she'll give us the perspective of the inpatient perspective of what she sees in the hospital when patients present with COVID-19 and how COVID-19 affects individuals with diabetes. Next, we have Dr. Lindona Marast, who is an internal medicine and primary care physician. Her perspective will be coming from the outpatient. That is when patients with COVID-19 come into the clinics, what does that look like? We also have Dr. Karen Clover, who is a board-certified physician specializing in psychiatry and teaches stress reduction mindfulness skills that increases professional and personal success. As we know, we have, as Black people, we're always told to pray about it, and we have some sort of love-hate relationship with therapy, but all of us are really going through it now. I'm pretty sure on the live right now, somebody knows someone who was either infected with COVID-19 or lost somebody with COVID-19. And that's not only the half of what we have to grieve, because we cannot, we cannot bury our loved ones how we would traditionally want to bury them. But also we have so many people right now who are losing, whether that be weddings, graduation is such a big thing right now, time spent with our loved ones and everything else. So she's here to talk to us about how can we best maintain our sanity, how can we best maintain our health while we're taking care of individuals and while we ourselves are infected and with everything else going on. Next, we have Dr. Negan Hajizadeh, who is a pulmonologist and a critical care physician, and she's in the front lines on the ICU. She's like the superwoman at Northwell doing clinical trials and being in the ICU and doing her own research studies. And so she's here to tell us what it's like in the ICU, what she's seen in the ICU, as well as how COVID-19 affects us, our respiratory functions. Next, we have Mr. Anthony Roberts, who is now 2 years retired from the military after serving 27 years of service and 3 deployments. And now Mr. Roberts can add to his long list of service that he's a COVID-19 survivor, and he's here to tell us his story about what transpired. Moderating with me is the lovely Dr. Janice Gassam, who is a diversity and inclusion consultant who delivers workshops for organizations and institutions. She's also a business professor. She's also a professor of business, a TEDx speaker, and a Forbes contributor. And last but not least is me. I am Dr. Maya Williams. I am a health disparities researcher at Northwell Health. A lot of my research focuses on diversity and inclusion and getting access to care for minority individuals, particularly immigrants and Black and Brown people, as well as Hispanics. And this is why this conversation that we're having today is so important, because it will help us to give individuals the necessary information that they need, as well as have them get access to care in terms of where to go and what to do. Before we start the session and I hand it over to Dr. Janice Gassam, I would like to take this opportunity to thank the Black Educators Community, Inc., who are responsible for sponsoring this event, as well as Dr. Vashti Book, who is a parliamentarian, and she's on right now. So thank you so much for taking time out of your schedule today to speak with us and to be here with us. Also like to thank Tiffany Harden, who is moderating in the Facebook chat, and the entire trial and Department of Medicine at Northwell Health for making this session possible today. I'll now hand it over to Janice Gassam to continue with the session by asking questions.
Thank you so much, Dr. Williams, for those wonderful introductions. And thank you so much to everyone for taking time out of your busy Sunday to be part of this panel. We're really grateful that you all are here bringing your knowledge, skills, and expertise to share with the world. So, Anthony Roberts, I wanted to start off with you. Could you share with us a little bit about your particular COVID story and your experiences with COVID thus far?
Certainly, doctor. In the middle of March, I began having symptoms. You know, it's kind of crazy how it developed, doctor. I went to the local city MD, told him I wasn't feeling well, and this is in the middle of March, doctor. So the first time I went, they said, hey, don't worry, it's just an upper respiratory infection. Take some Tylenol and you're gonna be fine. And I didn't have a fever. And they ran the swab through my nostrils and stuff like that. And they said, hey, don't worry about it. But this persisted from, I would say, mid-March, to get my time frame correct here, to near the end of March, because there was 2 weeks between the times I went from the first and second time to city medical doctor. So the second time, they told me the same thing. What ended up happening when I wasn't feeling well, for the last, right after the second visit, prior to me going into the local city MD, I was having problems breathing. I'm an avid runner. I try to run at least 5 days a week, doctor, to keep off the weight, because, within our community, African Americans, we have high diabetes and blood pressure and all these other negative things. So I try to practice positive self-health. So anyway, I went to city medical doctor the second time, and they said the same thing. So what ended up happening, I emailed my doctor at the Brooklyn Veterans Hospital. She told me, hey, Sergeant Roberts, this sounds like either you have COVID, pneumonia, or possibly both. So the day I got that email, I told my fiance, hey, I'm not feeling well. We'll just go to the hospital in the morning. She said, no, let's go right now. So that doctor, to be honest, I think it was March 30th. And when I put on the mask and the gloves, I wasn't feeling well, having problems breathing. When I went to the Veterans Hospital, they admitted me. Of course, they took my blood pressure and all that stuff. What happened was they swabbed me, but before the swab results even came back, the doctor on duty, he ordered a chest x-ray. And whatever he saw on the chest x-ray, if you ever see, excuse my French, an Indian doctor get red, he said, hey, young man, you know what? You can't go anywhere. I believe you have the COVID. And he sent me right upstairs. So between me leaving the emergency room and getting upstairs, I think they had me on the 11th floor. I started coughing and really like going into it, you know, and they put the mask on. And doctor, I actually ended up spending, I think I got in there March 30th and I left April 16th. So my experience within, of course, you know, I never had the ventilator, but they kept putting the mask on me, and every 4 hours they would take blood or they would come and get blood pressure. I had an oximeter where they would check my pardon me, they would check my breathing and my oxygen levels. And it was my first, I would say 12 days was the roughest part, because they moved me from infectious care to the ICU. And in ICU, you know, I was kind of scared, you know, I had the mask on, and all the machines going off 24/7, it seemed like. And I couldn't eat, and you know, I kept losing a lot of weight. And of course, they ran their tests periodically to check my vitals and how well I was doing. And I wasn't doing well, doctor, to be honest. I would say if I spent 17 days there, roughly, I would say 14 days were the hardest. Okay, so that's my little personal experience.
And now that you've basically recovered, Anthony, from COVID-19, have you noticed any changes to your body or any effects that experiencing the virus has had now on you?
Mentally and physically, yes. For example, of course, I lost a lot of weight because of my limited intake of food and nourishment there at the hospital. And I would, like we say in the military, post-traumatic stress, because in the hospital, you know, you hear my roommate passed away one night. I got, you know, he was I would say 10 feet away from me on the other side of the room there, and it was sad to see someone pass away. They come in, they didn't tell me anything. The lights go on. I couldn't sleep very well. They bagged that individual up, and it was, I would say, mental stress, because it's like you know, you're on the battlefield and you see your buddy pass away, and you still have to function for the good of the platoon or the good of the battery or whatever environment we were in at the time. And it's a mental stress to see somebody pass away. I'm looking at the news. I'm 49 years old. So I'm looking at the news, and because we have portable TVs in the hospital bed, and you hear people dying, and people younger than me are passing away. So I'm like, oh my God, I'm healthy. I don't have any pre-existing conditions, but you know, it's panic to the body, you know, to the mental state of the individual. And of course, different people at different stages / phases encounter different things. How he or she is dealing with it, maybe someone's not as strong, or they know they have a pre-existing condition, doctor, so they in a panic. So I'm looking at the news, people younger than me passing away, and you know, that, I would say, the mental blockage there, that was traumatic. And physically now, like, I was scared to go outside. A couple of days after I got back, I was like, I'm not going outside. I'm scared. I didn't know if I could get a relapse. So it was like, I'm going outside and I'm so nervous. And I get to the park, mind you, and 90% of the people has masks, and the other 10%, they don't have masks. So I'm staying far away from those jokers, because I don't know. Again, the science is still being developed. So I don't know if I can get it again, doctor. So I was so, like, I'm a grown man, 6'3". I was 230, and I think I left the hospital at 192, I want to say. You know, so I was just scared, and the mental stress is there, because I don't know, can I get it again? You know, so to answer that question is a couple angles I can go at it, because right now I'm still scared to go outside, but I got the mask on, I got my hand sanitizer, I wash my hands so much that it feels dry now. You know what I'm saying? So that's some of the things I went through, doctor, and that I'm still going through right now. I'm knock on wood. My family, they prayed for me, and I paid attention to my healthcare providers at the Veterans Hospital, but still, and I retested since I came out. I went locally and I got retested. So I retested on Wednesday. They called me on Friday and told me I was clear. To be fair to the Veterans Hospital, I went last Monday, doctor. I took a series of blood tests. All my blood results came back positive. The new chest x-ray came back positive as well. Whereas I still just have like maybe some pneumonia left in there, but it was like 92% clear. So that's a good thing, doctor. Pardon me for being long-winded.
No, but thank you so much, Anthony, for sharing your experiences with us. So I wanted now to move on to Dr. Allison Myers. Could you share, based on your knowledge and expertise, what are some underlying conditions that make a person most at risk for things like complications from COVID-19?
Thank you, Janice. So what we've been seeing from data in China, as well as our own experience, is that COVID in America is different than COVID in China. And a big reason why we've seen so many differences is that we have a much larger population of obese patients here. And it's, of course, unfortunate that in our community, especially we as Black women, tend to have the highest rates of obesity when you look at other ethnic minorities. So being obese itself is going to put us at risk. So we define obesity by using BMI, and you can use a BMI calculator online. Then when you put in your weight, you put in your height. And if your BMI is 25 or greater, you're considered overweight. And if it's over 30, then you're considered obese. So even if you're overweight, it's going to also increase your risk. But if you're obese, you're definitely going to be at increased risk. And of course, all of the conditions that we see that come along with obesity will increase your risk. So that would include sleep apnea, diabetes, hypertension, as well as heart disease. In addition, people who have immunocompromised states. So those are people who may have a weakened immune system due to having cancer, people that are undergoing chemo, people who've had transplants of kidneys, hearts, or any other particular organ. They're on medications that also make their immune system weaker. Obviously, people with chronic conditions like HIV, those are the people that we're going to be the most concerned about. But I think the key take home that we've also seen is that people who don't have underlying conditions can also get severe cases of COVID. There was recently an article that came out from the New York Times when they were talking about Mount Sinai, did a study, and they showed that there are numerous young people who were getting strokes due to COVID who had no underlying conditions. They're in their 20s and 30s, because one of the things that we've learned about COVID that makes it so much different from the flu is that people are prone to getting clots. And those clots can affect different parts of your body, including your brain. It can cause strokes. So we've seen patients who are a lot younger getting strokes than you would normally expect. That has nothing to do with diabetes or hypertension. So the take home is that COVID is not a one size fits all illness. There are people who will be older. We've seen the case of the lady who was over 100 who recovered from it. And we've also seen 20 and 30 somethings pass away. We had a 35-year-old who unfortunately passed away that we took care of. So I would just say everyone needs to be safe, wear a mask, and protect themselves accordingly. And I just use universal precautions. As far as I'm concerned, everyone has it, and I just keep myself safe.
Thank you, Dr. Myers, for sharing that. So Dr. Marist, could you share, I think there's a lot of confusion around the coronavirus and the flu and allergies. So could you just share a little bit with us about how the coronavirus is different from influenza and allergies?
Sure. First, I just wanted to, thank Mr. Roberts for, giving his story. And when I was listening to, him just describing his symptoms, it just made me realize that it's very variable, the disease, COVID-19. And I want, people to understand that this is a new disease. Prior to 2019, this disease didn't exist before. And so the common symptoms are cough, fever, fatigue. You'd hear patients describe having extremely, severe fatigue and shortness of breath. Sometimes people present with other symptoms. Sometimes people might say they have a loss of sense of taste or loss of sense of smell. Some people might mention diarrhea and body aches, but the cough and fever and fatigue, as well as the shortness of breath, tended to be the most common symptoms that patients have. So in terms of, the coronavirus versus influenza, they're similar in that they both cause upper respiratory infections. So like I said, some of those common symptoms like the cough and the shortness of breath, you can see that in both. They both can, turn into pneumonia, which can be seen on the chest X-ray. And how they differ is that, similar to what Dr. Myers mentioned, is that the coronavirus, what we've come to see is that it's not just an upper respiratory, illness. It affects many of the other organ systems. So some people might present to the emergency room for the first time, finding out that they have diabetes. We found that people who are hospitalized, they might have elevation in their liver function tests. So the disease is affecting the liver, it can affect the pancreas, and also going back to the fact that it can cause strokes. These strokes can cause, blood clots. These blood clots can occur in different parts of the body, in the brain, causing a stroke, in the lung, causing a pulmonary emboli. So it's different from influenza in that it affects multiple systems, and that is very new and very different. Also, I wanted to mention what Mr. Roberts said about, he had, a bout of the illness, and the question is now, is that it? Does he have immunity for life? And that part is not clear, and the science isn't. It's not 100% to tell us whether or not is it possible that someone can get infected again. So for example, someone could get influenza in 2019 and then come this fall, you can get influenza infection again because it's a new strain. So it's not clear if the coronavirus is like an influenza where you can get hit multiple times and you can get infected again. Or is coronavirus like, I think about it like chickenpox, where if you get chickenpox once as a kid, you have lifelong immunity, you're not going to get chickenpox again. So we're still trying to figure out, for those who've had the coronavirus and you have immunity, you develop the antibodies, are you infected and you have long-term immunity for life and you won't get it again? Or is it possible that you can get infected many times? So that part we're still trying to figure out.
Thank you for sharing that with us, Dr. Marist. So Dr. Glover, Anthony spoke about the toll that COVID-19 can play on a person's not only physical health, but also their mental health and well-being. Could you share some strategies you can suggest for us all to protect our mental health during this global pandemic?
There we go. So one of the things that I really appreciated about Mr. Roberts, his account of what he went through was that he had people in his life who were sending him really good energy. And I'm wondering whether Mr. Roberts, whether there was any communication when you were in the ICU. Were you allowed to have any kind of FaceTime or video chats with them?
Okay, doctor, fortunately for me, the night my fiance was leaving the hospital, she gave me my good old cell phone. So I had it on my bed next to me. And when I could, when I had the strength and when I had the time, I would text, friends and family. I didn't do too much FaceTiming because if you saw my face with the beard grew in and the mask, and I didn't want to, like my mom, if she's seen that, it would make her crumble. So intentionally, I would just, send a photo of when I could smile, and I didn't want to do a FaceTime. She would, she's older, she would crumble, even my friends and family. So I try to keep it to a minimum. And I was, luckily I had my cell phone to communicate when I could. So I would jump on just maybe 20 minutes a day, communicate with loved ones and jump off. And
Okay.
that's it.
So that's major, I think, right? Because for lots of people, when they're in the hospital, even when they don't have COVID, they feel very isolated, right? And we know that maintaining our social contacts is stimulating for the brain and for the body. So we want to keep communication. So if a loved one has to go into the hospital, you're making sure you give them a phone and a charger. Right? So that's one thing, so that you guys can be in touch, and hopefully you can FaceTime or do some kind of video chat. Now, for those of us who are not ill and we're just trying to cope with the threat of COVID, right? A big part of waking up every day is sort of recognizing this is day 4,080 of COVID, right? And we still have no cure and no vaccine. And having the courage or the strength or the faith that you can leave your home and you might just be okay. And that maybe you deserve some kind of joy, right? And maybe you have to do things that you never used to do before to take care of yourself. Maybe you have to embrace a hobby, like something artistic. Maybe you've got to be physically active and rock your mask and still go for a bike ride. It takes courage and faith and community to keep on going through these times. I think a big part of what I'm hearing from my patients is a certain like, well, look, if this is about to be the end, like, let me make sure that I say the things that I've always wanted to say, that I express the love I've always wanted to love, things like that. And I also want everybody to be aware that I have a subset of patients who went through a lot in their childhood, lots and lots of trauma. Some of them are coming to me and saying, oddly enough, I'm good. I never knew
that I could be good in chaos. And I was like, well, did you not realize when you were a kid, you found a way to be good through chaos? And so what you thought was your tragedy when you were a kid, right? As somehow it enabled you to function amidst chaos. So let's also not forget that we have accumulated lots of coping mechanisms, some of them great, some of them not so great, but some of them are kicking in right now, and they're enabling us to get rest. They're enabling us to get up and love our families and feel okay some kind of way.
Thank you, Dr. Glover. I know that Maya mentioned that there is a question from the audience.
Hi, this question is for Negan, because a lot of the participants in the Facebook Live right now, they're kind of saying that the medical terms are sort of going over their head. One participant wanted us to clarify the difference between pulmonary embolism and upper respiratory. So would Negan be able to clarify this for us, please?
Oh, sure. Yeah, a pulmonary embolus is when you have a blood clot to the lung so that it prevents oxygen and carbon dioxide from exchanging from your blood system into your lung system, and it can actually be fatal. An upper respiratory tract infection is like the sniffles, a cold, kind of sinus congestion, the cough. That's an upper respiratory tract infection. COVID-19 is a disease that includes the lower respiratory tract. So now we're talking cough and other symptoms that have been described as well. COVID-19 as the disease is also associated with a condition in which your blood is clotting more easily. And as a result of the blood clotting more easily, you may be at higher risk of a pulmonary embolus. So that blood clot to the lung that's preventing the oxygen exchange, in addition to the normal lower respiratory tract disease, which is the cough and the fever. So that's the distinction between the term pulmonary embolus and a respiratory tract infection. One includes the lung, that's the respiratory tract infection, because the lung is your respiratory tract. And the pulmonary embolus is the blood vessels that feed your lungs, that picks up the oxygen and gives off the carbon dioxide. That's a pulmonary embolus.
Thank you for that. And just to have a follow-up question, because Anthony mentioned earlier that he was placed on oxygen and not a ventilator. So could you tell the audience what would make somebody be on oxygen versus a ventilator?
Yes. In short, the difference between being just on oxygen and being on a ventilator is whether you're able to maintain the oxygen and carbon dioxide levels that your body needs without the assistance of a machine breathing for you. A mechanical ventilator is a form of life support, wherein your lung is assisted in the breathing and the exchange of oxygen and carbon dioxide through a machine, the mechanical ventilator. In many patients, just having oxygen supplementation, and there are different forms. One is nasal cannula, which is that like thing that goes in your nose, the tubing that goes in your nose, that's called nasal cannula. And when people need more, they go on a mask that blows oxygen into their airways. That's a non-invasive form of getting oxygen to your body, because COVID-19, the disease, is associated with a lot of need for oxygen. So in many patients, like Mr. Roberts, just having oxygen through a non-machine, through an oxygen machine, is enough to support you. In some people, they need to actually be on a ventilator. And when we say that someone's on a ventilator, we in most cases mean that they're deeply sedated and have a breathing tube in their mouth into their airway. That's the difference when we talk about being on a machine, a life-supporting mechanical ventilator versus on oxygen.
Okay, thank you for that. That was a very good. That was a very good description. Janice, do you have any questions, or would you like me to continue with the questions?
No, I think you can continue with the questions. I was going to have a follow-up to ask Dr. Negan.
You could go ahead with the follow-up.
Okay, so hypothetically, I want you to imagine that I am a person who's recovering from COVID-19, but I still have a very dry cough and my breathing has not gotten back to normal. So what should somebody in that particular situation be doing?
Yeah, this what we know about COVID-19. So I myself,
Dr. Nagin, it's a little hard to hear you.
what we know about, hear me better now?
No, it's still low, the volume.
Okay.
Yes,
Maybe my
that's
internet.
better.
Oh, better?
Yeah.
Okay. So what we know about this disease is it takes a long time to heal. A long time. I mean, 3 weeks, sometimes 4 weeks. So the first thing we say to everybody, including those doctors who are taking care of patients, including myself in the hospital, is that this is going to take time. Take time. And so what we need to do during this time period is try our best to make sure nothing else happens to us. So those blood clots I was mentioning about, what we can do is we can make sure we're mobile, we're active, we're moving our legs, we're moving our hands, making sure that our musculoskeletal system doesn't become weaker while our lungs and the rest of our body tries to recover. If you have a dry cough and you don't have a fever and your mental status is okay, you're thinking the way that you were before, you're going to have exhaustion, you're going to be fatigued. A lot of people, and again, with this disease, there are many ways of presenting. The majority of people have fevers, they have a dry cough, and severe fatigue. However, there are some of us who don't have fevers, have low temperatures, have extreme fatigue, and different forms such as headaches, right, and weakness. So there are different forms of this disease. Uniform across them all is the time it takes to get better. If you're having a cough and difficulty breathing, but it seems like it's been the same that it's been since you saw your doctor and were checked out, and by checked out, I mean specifically that your oxygen level was where it needs to be, because this disease can make your oxygen levels quite low. So if your oxygen level is where it needs to be, above 90% or whatever your doctor thinks is appropriate for you, and you're having a dry cough, but it's taking a long time, that is the disease. It's taking a long time. Surely, if you have new symptoms, like if you're having trouble thinking, you're having chest pain, your skin color is changing, you're finding that you're really dizzy and unable to get up and out of bed, any of those strange things that are happening that are different from when you saw your doctor, you absolutely need to tell your doctor. I'm talking about if you see your doctor today and she or he checks you out and your oxygen level is okay and you have a dry cough, the fact that you have that dry cough a week from now or a week and a half from now, but everything else has stayed the same, very likely that's your disease taking time to get better. What's important in this setting is, and as my colleagues have discussed, is taking care of your musculoskeletal system, moving around to the extent you can, to the degree you can, as safe as it is for you, being in touch with your loved ones, and trying to teach yourself patience. This is going to take a time, and I'm going to find something to do while this takes its course.
Thank you so much, Dr. Nagin. So Dr. Maris, I think a question that a lot of people have is, what do I do if I start to feel unwell? So if you start to feel kind of like you're not feeling well, but you don't know if it's COVID and you can't get a test, what are some home treatments you would recommend people start doing to not make things worse if it does turn out to be COVID?
Yeah, so it's interesting. In the beginning, a lot of people would call and would have symptoms that are very or highly suspicious for coronavirus. And a lot of times we'd have to tell them, whether or not you're tested, even if the test is positive or negative, the treatment essentially is the same in terms of what we would call supportive care, the same as if you had, an influenza, a flu. or regular, just sort of viral illness. And I apologize if I'm getting too, technical with the terms. I'm going to try not to do that. But if you think about, you're coming down with something, you're not starting to feel well, some of the main things are things like just stacking up in your vitamin C, right? So whether it's lemonade, orange juice, whatever your go-to is, some people like to go and buy, emergency from the pharmacy. So those kinds of things that help to like boost your immune system. So I would add on things like, vitamin D, some zinc, drinking water, staying hydrated, getting sleep. Those things from a primary care perspective is what we would call supportive care, right? Like we're not treating a specific condition, a specific disease, but we are treating the symptoms. So if you have your, sort of your go-to home remedy or the things that you use to boost your immune system at home, as long as they don't interact with any kind of chronic medication that you take, as long as there's no interaction from that perspective, then those are the things that we would recommend.
Thank you, Dr. Maris. And Maya says there's a follow-up question for you from the chat.
Hi, Lindona. So somebody in the chat asked, is there any advice for building the immune system for people with health conditions such as the flu, HIV, and diabetes? And Dr. Myers can also speak about the diabetes part. So could you help us, could you explain that to the individuals, like what we could do to boost our immune system? And we know that we in the Caribbean like to drink our ginger and our lemon, so to let the people know what is it that they should do instead of the, usual herbal medicine that our grandmothers told us about.
So that's what I mean. If you're used to drinking your ginger and your lemon and you have your concoction, go for it. As long as it doesn't interact with whatever common medication you take, just run it by your doctor, make sure it's okay, then it's totally fine to do that. My approach to, food and nutrition is you are what you eat. So as much as you can, try to eat a well-balanced, well-rounded meal, breakfast, lunch, dinner. That's really the best thing you can do when it comes to boosting the immune system. And then the other things that I mentioned, such as, your vitamin D, your vitamin C, zinc, things like that, but really just making sure you're getting enough of all the types of nutrients is really the best way to boost the immune system, that as well as exercise. And I should have to mention in terms of, conflicts of interest, I don't have a conflict of interest per se, but I am a primary care doctor, and I do think everyone should have a primary care doctor. So I just have to say that.
So follow up on what Lagana said, personally, what I do, and I've been telling my patients, especially for Black folks, is vitamin D is so important, because unless if we're out in the sun for 30 minutes a day, we're not getting an adequate supply. And we're just coming off of being in the winter time. So for those of us in the northern latitudes, especially New York, we haven't been out all winter getting 30 minutes even before the lockdown. So usually I would say take 1,000 to 2,000 international units of vitamin D a day. Also, I take vitamin C. My dad who has diabetes, I gave him a big old bag and told him to take it every day. And as a side note to my people with diabetes, I know Dr. Maris said something about drinking juice. For the people who don't have diabetes, okay, but for my people with diabetes, please don't see that as an excuse to start drinking juice. It has too many carbohydrates for most of you. So you can get a fresh orange and cut it. Ideally, it's not a big one that's like this big. You can do 2 cuties or a tangerine to get adequate vitamin C, but don't think that because of what Dr. Maris said, that that's a cosign on you to start drinking juice for my people with diabetes. One other thing I just want to mention is that when your diabetes is poorly controlled, that's also not good for your immune system. And several of my patients actually stopped taking their medications when they got sick with COVID because they weren't eating. And I understand a lot of people have really poor appetite and don't eat as much, but the problem is that COVID is affecting the liver and the pancreas in such a way that it's making people's sugars go high. And for all of my people who don't test themselves routinely, who go by symptoms, they're not realizing that their sugars are shooting up into the 300, 400, 500s. So I would greatly also recommend that you're testing your sugars for the people with diabetes to make sure that they're well controlled, that you don't stop your medications. But if you have concerns about your medicines, instead call your doctor and discuss with him or her, because some medications may need to be reduced in their dosing or alternated to avoid side effects.
Dr. Myers, it seems like there's another, I'm sorry, Dr. Glover, I know you also have a follow-up. Maya let me know that there's another question for you from the chat.
Dr. Myers, and it's similar to that you're talking about diabetes. One of the things that we know is that after 6 weeks, individuals are starting to see like COVID toes. And somebody asked, which is similar to COVID toes, somebody in the chat asked, is there specific guidance? Oh, I'm sorry. The question in the chat was, hold on, let me get it. It's moving too quickly. The question was, should skin discoloration be equated to skin exfoliation, especially on the palms and soles? Is that related to COVID toes?
Can you repeat what the question was again about the skin? Was it exfoliation you said?
Yes, should skin discoloration be equated to skin exfoliation, especially on the palms and soles?
Okay, so COVID toes is similar to a condition called Chablans. And what that comes from is that you can get inflammation, which builds up in the vessels in your toes. And what typically happens is not that the skin is looking like it's exfoliated, it actually turns red or purple. And so usually you see this in like really cold or humid temperatures. So people who traditionally have this condition, Chablans, they warm their hands and the discoloration goes away. So they're not sure why this is happening with people who have COVID. And again, the thought is it may be a similar presentation that the inflammation that Dr. Nagin mentioned earlier is occurring, or the other possibility is that some of these little blood clots are small versions of them are going to the vessels in the toes, and that's what's causing the discoloration. So it's either a buildup of inflammation possibly, or that some of these little blood clots that we're seeing are going to the toes causing this discoloration, which should not look like necessarily that your skin is coming off, but usually it's a reddish or purplish discoloration. Some people may have some discomfort with it as well. For those of you who've ever had frostbite, it looks very similar to that in appearance.
Thank you, Dr. Myers. Were there more questions in the chat, Maya?
No, that's it. We could now.
Oh, I'm sorry, Dr. Glover. I know you had follow-up.
It's just that when Dr. Marist was talking about people coming up with their concoctions, I was on, there's a well-known sort of herbal, I don't know exactly how does one describe Queen Afua, right? She makes lots of recommendations for herbal remedies and for holistic living. And I was watching her live because I know a lot of people rely on people in the community to say, you know, here's what our ancestors did. We should be doing the same thing. Well, let's just make sure that we're being very judicious about that, because I have a lot of patients who will come to me and say, you know, I've started taking an herbal tonic. It has lots of valerian in it. It has a little St. John's wort in it. And next thing I know, I'm like, all of these are affecting your liver. Right? Some of these herbs are processed by your liver, and please just talk to your doctor and let them know about the tonic. Always let your doctor know about the tonic, because it has the potential to interact with medications that I may be prescribing for you, and I need to know that so I don't mess up your liver, so that I don't mess up your pancreas. That's all.
Thank you for that, Dr. Glover. I also like my concoctions, like Maya stated, like the sour sop and the sea moss and all of that, but that's great to know. Mr. Roberts, circling back to your story and what you shared, could you tell us what precautions, if any, you and your family took after you returned home from the hospital?
Certainly, doctor. When I got home, I, of course, practiced an additional 14 days self-quarantine. I kept the regimen. I'm still keeping with the regimen of all the medications they sent me home with from the Veterans Hospital. When I do go out now, doctor, of course, the mask and the gloves. Coming home, getting in the door, everything goes in a plastic bag, or it goes in the corner to be washed with, to be washed with hot water and whatever else we put in there. And an additional precaution, coming in from outside, with the clothes, putting them to wash, going outside, having the surgical gloves. Like if I have to pump gas now, I'll put the gloves on, because, again, I'm like going through post-traumatic stress here, and I'm scared about touching anything. So those practices are some of the things I've implemented since returning home, doctor. you know?
Thank you so much,
Sure.
Mr. Roberts.
Mm.
Moving to Dr. Maris again. So there's been a lot of talk about antibody testing, and that is maybe the solution, or what we will see in a lot of places we enter, they'll be testing antibodies. Could you explain to us the difference between antibody testing and serology testing, and how would we know which type of test is best to get and when?
Yeah, so antibody testing and serology is actually the same because we're testing the blood. So I think it's important to make a distinction with what it is that we're looking for when we are talking about the test. So when people say they want to get the coronavirus test, it's either a swab to the nose or a swab to the mouth. And when we do that test, we're actually looking to detect pieces of the virus. So that tells us if you have an active infection right now. And if you have an active infection right now, that means the virus particles are on you. That means you are able to potentially transmit the virus to others. It's unclear how long people, remain contagious. The belief is that, within 2 weeks, it's very, very small, but there is the case that people may actually, have viral particles on them for, weeks even after they are better. So that part of the science, again, still is not clear, but that's the initial test. When people talk about, I need to get, a coronavirus test, it's either an oral swab or a nasal swab. So that's testing for viral particles. When we talk about serology, it means we're taking a blood draw. And then when we take the blood draw, we are actually looking to see if you have an antibody. And the idea of the antibody goes back to, it's a germ, the virus, you get exposed to it, and the body does this natural thing where it tries to fight it off. In the process, it makes antibodies, which the idea is if you get exposed to this germ, this virus again in the future, your antibodies will attack it. And so therefore you should be immune, or at least you should have, a mild infection because your body's able to fight it off. And so what we're trying to do now is for those who potentially had the coronavirus, or if you're not sure if you had it and there's a question of whether or not you did have the infection, by doing the serology test or the blood test or the antibody test, we're looking to see if you have immunity against coronavirus.
Thank you, Dr. Maris. Dr. Nagin, to kind of circle back, we were talking about ventilators and the process of being placed on one. So could you share what some of the long-term effects, if any, are to ventilators on our lung functioning?
Sure. I would say that for all of us, if a family member or if we ourselves are going into the ICU and the conversation is happening about being on a breathing machine, that this is a long course. And this is what I've been informing people who have been in interviews with me or other family members, is that as compared to other diseases, I go back to this being a long disease.
It's a little hard to hear you.
Is it better like this?
No, it's like the volume is low.
Okay, is that better? No?
Yes.
Okay, like this?
That's better.
Okay. So that this is a long course. The course, when you're on a breathing machine in this disease in particular, a lot of places require heavy sedation so that you need to be in an induced coma. And sometimes we're putting patients on medication to paralyze them so that we can breathe for their lungs without any problem. No? Still problem?
Yeah, it's like it'll be high and then it'll go low again.
Hold on one sec. Okay, maybe it's better like this.
Yeah, that volume is perfect.
So I took out the headphones. Sometimes we put people on paralyzing medications so that we can breathe for their lungs. And in extreme cases, we try to bypass the lungs by going through a machine called ECMO, where we take the blood out of the body and into a machine instead of the lung and clean that blood out and go back into the body. In all of these cases, we're talking about your body once you get to the point, if you get to the point, or your loved one gets to the point where we can start to wake you up and allow you to breathe on your own. Because of all of this medication that was required to breathe for you, and also because of this virus affecting so many of your organs in your body, you're extremely weak. not to mention the mental health consequences that Mr. Roberts mentioned. If you can imagine being awake and going through all of this, being in a deep coma and coming in and out of that coma, you're going to have many memories that you might not be able to distinguish what was real and what was not real. When you're not in such an induced coma, it's easier for you to remember, oh yeah, that was something that happened. It was very traumatic. As opposed to when you're in a deep coma, you might be confused about what was reality or what was not reality. So we know from people who survive critical illness that there's something called post-ICU syndrome, that they remember snippets of what happened in the ICU, and that their mind has filled in some of the things that might have happened that's associated with, terrible nightmares, for example, or anxiety. So there's the mental health component that Mr. Roberts mentioned takes a while to recover. But in addition, now you have the musculoskeletal weakness, extreme weakness in the limbs, extreme difficulty taking a deep breath, and kind of feeding yourself. I urge people to realize that this takes a while. That was with physical therapy, and we're talking weeks to months of therapy, from head to toe therapy, because we're used to thinking of kind of physical therapy and occupational therapy, but also your mind therapeuting the entire body and the support of the loved ones around us. I do want to give that positive message. I think in this era, it's such a frustrating disease. We don't know when it's coming. We don't know who might be carrying it. And when we get sick, we're sick for a long period of time. And I think it's important to underline this message of hope and patience and the support of our networks and our communities together with time. You're going to get better. It's just going to take a long time. I will say that for some of us, particularly those who have a very severe form of this disease, we do know that some people who have comorbid diseases, so coexisting conditions, and in people who are older, and there's definitely some predisposition that we are trying to understand whether it could be genetic or not. For some people, the disease will have a very severe course, and the intensive care physicians or the inpatient doctors may say that this is taking a course that seems to be more severe and might not have a good outcome. So kind of speaking continually with your inpatient doctors over how that is progressing for your loved one is important as well.
Thank you, Dr. Negan. I really like the part that you mentioned about our mental health, because I think it is so important. I mean, even for me, who has never had coronavirus, but every time I feel like my throat is itching, I'm like, Rona, is this you? Like, I get all, excited and scared, and I'm, doing like rubbing my throat with shinging oil and doing all sorts of things. So I don't know how to take care of my mental health. So what would Dr. Glover suggest, and to how to maintain that anxiety that we might have during this time, and try not to freak out every time it's like, and especially in public. I also want to touch on that in public, because yesterday I went out and I noticed that whenever somebody sneezed, whenever somebody coughed, whenever somebody was not wearing mask, like everybody's like, are you insane? So could you please help us remove that stigma, or tell us what is it that we could do to get rid of the stigma?
Yeah, I mean, I think there's a few things that you mentioned. Anxiety. So just a word about anxiety, that sometimes anxiety is good, right? Anxiety makes us watchful. It makes us vigilant. It makes us aware and look for danger. The hard part is that constant chronic exposure to anxiety and to stress has the potential to wear us out. So I don't mind if you have a little anxiety and you use that to make sure you pack your mask, and to make sure that you have your gloves, and to make sure you don't touch your face. Fine. That level of anxiety is cool. The level of anxiety where it becomes uncool or potentially harmful is when you can't sleep, right? Because we know sleep is very important for immunity. So the most important thing is perhaps to be aware when your anxiety is like overshooting the mark, and when it's making you and other people around you miserable. So one thing I would suggest is some sort of exercise practice, because you periodically need to be able to leave your mind and just be in your body. So if you have an exercise practice, please keep on doing that. Other things, please watch how much alcohol you take in, because alcohol often helps us feel relaxed. The downside is alcohol can affect our sleep negatively. It can be habit forming. And maybe the hard part is distinguishing between when we just want to relax and when maybe we actually need to acknowledge how vulnerable we feel, and we might need to reach out to a friend or a loved one for some support, because perhaps not all the solutions are in that bottle. Some of the solutions are in here and up here. So, and then the other thing you mentioned was stigma, right? And so by that, when I think of stigma, I think of when I'm out and I know that somebody may have been ill, or they may look like they're kind of ill, and I have to figure out a way to like navigate around them and still trust that I'm probably going to be okay. So I'm going to tell one story. In the midst of the virus, when Mr. Roberts was in the hospital during that period, when the cases were extremely high in New York, I had a doctor's appointment that I could not miss. I had to go see my doctor. So I put on my little mask and I got on the number 7 train, because it's a super crowded train. And I just was like, okay, Jesus be a mask. So and everybody else thankfully had their masks on. I got to my doctor. She had her mask on. I kept my mask on. She reached out to me a day later and she said, Corinne, I have a temperature of 101. I'll keep you posted about my results. I'm going to go get tested. My doctor ended up having COVID. I did not. This doctor was in my face like this. We were this close to each other and we both had our masks on. So I really, really want people to know that in lots of ways, just because somebody sneezed 6 feet away from you or 3 feet away, you're probably gonna be okay, right? You're probably gonna be okay. And I realize I'm just telling you my own personal story, and maybe it's not generalizable to the whole population, but I just want people to understand that there's a level of risk, and there's which is different from the level of vulnerability you may feel. So just keep that in mind. And just as you move through the world, you keep on gauging like, okay, I'm here in my body. I'm taking a deep breath. I'm here. I'm taking another deep breath. I'm here. I'm taking another deep breath. And as you keep on practicing that awareness of your own body being healthy, I think you will start to find that it's its own affirming process, and hopefully there's some relaxation that happens when you realize that with each moment, you notice the air around you, you notice the colors of the flowers, you notice how many people are walking by you, that process of being aware of your surroundings and aware of your own body ultimately is called mindfulness, and that's a practice that can help you make it through stressful circumstances.
Thank you for that, Dr. Corinne. Because usually we need to practice mindfulness, and I do that sometimes where I'm just like, I'm here, I'm in this moment, I'm safe, I haven't been outside my house, I haven't touched anything, I haven't been in contact with anybody. The chances of me getting this virus is very, very limited, and I'm just definitely taking the necessary precautions that I need to take. So now it's like 5 p.m. and I wanted to give the audience an opportunity to ask questions. So I will be looking for the live chat now and just be shooting questions to anyone who believes that they could answer the question, not directly or specific to one particular individual, but if you believe that you could answer, just go ahead and do that. The first question I have is sort of like HIV related and deals with, again, comorbidities. But somebody asked, is there a specific guidance for people living with HIV and those who inject drugs?
So I work at Montefiore, where we have a very extensive buprenorphine program, and I worked in HIV for 8 years. And one of the things that we've been talking about for our patients is making buprenorphine widely available. So you don't necessarily have to go into a program, and like some people are being induced over the phone. So if for people who are injection drug users, We want to make sure that those people have access to buprenorphine during these times. We really don't want for there to be some massive health disparity and barriers to care if those folks are interested in getting help. The other thing I would say about HIV is just that please be in touch with your doctor, because some people are on medications that they have to make sure they maintain a routine to take, and getting thrown off the routine has the potential to throw off your CD4 counts. I leave the some other aspects of that question to some of my other folks on the panel.
Does anybody else have anything to say? Reference?
Yeah. I mean, I just wanted to say HIV, we consider it, it's a disease that compromises the immune system. So that means, you know, compared to someone without HIV, if you get, again, exposed to a germ or virus or so, you're not able to fight off that infection as strongly. So for those who are not familiar with HIV, that's something important to know. So when we think about HIV and coronavirus, if someone has HIV, I would think that would be, HIV be one of the conditions that would make them more likely to have, you know, a severe disease, the same as, you know, the diabetes and obesity and other risk factors. So HIV, in my mind, would be a risk factor for potentially having a more serious case of the coronavirus because it affects the immune system.
Thank you for that, Lindona. That was very informative. I have a question for, oh, Alison, did you have something to say?
Yeah, I just wanted to say that, you know, sometimes people think that because they have HIV, if they get sick, that this is going to be a death sentence, but I really don't think you should. I can tell you, I've taken care of people, obviously, but I also, on a personal note, I know somebody who got sick with COVID who has HIV, and that person sent me a picture the other day walking through the park with their loved one. So I just want to make it clear that, you know, yes, you may be more vulnerable to getting some of these infections, but it doesn't mean that it's a death sentence. And it's important to be in touch with your doctor and not just stop your medications.
Thank you, Dr. Myers. That was actually a good segue into my next question for Negan, Dr. Negan, but it looks like she's stuck. I'm not too sure if she is. Okay, I can see her now. So one of the questions that I have is, and Dr. Glover, she mentioned that as well, is that she went to see her doctor, and her doctor had COVID-19, but then she didn't get COVID-19. And it's the same for Anthony, well, Mr. Roberts, where he was in a household, he had COVID-19, but his fiance did not get COVID-19. And I have family members who are out there working 24/7 in the front lines, and they're not catching COVID-19, knock on wood. And it's also that I tell people in my family that instead of focusing on, say, 1.3 million people have the virus, or 300 people have died from the virus, or 300,000 people have died from the virus, they should realize that there are more people with the virus in terms of milder symptoms instead of people dying from the virus. So could you explain to the individuals on Facebook, like, why is it that so many people have milder symptoms and some, you know, and some people are dying? Like, what's the difference, or what makes us more prone to getting mild versus more severe?
Again, we as physicians and physician scientists are actively looking for an answer, and we will find an answer to this question. What we know for now is that those people who have a particular disposition to an over-exuberant immune response tend to fare worse than others. And we don't fully understand why that is. It may certainly be a combination of coexisting other diseases. It may be something like your immune system was really never as strong as we thought it would be, or some lines in the immune system. We're working it out. We don't know. But for me in particular, as a person who lives with this and sees actually the severest cases as an ICU doctor, it's really important for me to kind of reframe my mind when I leave the hospital and remind myself of the data and of the science that we have proven over and over again as this pandemic has spread across different countries around the world. That for most people, from anywhere from 70 to 80% of people, this virus causes a disease that doesn't need you to come to the hospital. It okay? And I'm careful with the way I use that language because I used to say that it's a milder disease. It is a milder disease. It takes a long time to get better for many people, but it's not to the point where you actually need to go to the hospital. And even for those who are in the hospital, most of those people are leaving the hospital. Like Mr. Roberts explained, it might take weeks. For some people, it's 4 or 5 or 6 or 7 days. For some people, it's 3 weeks. But for most people, they're leaving the hospital. Yes, there's a lot of trauma associated with it. In particular, in this disease, the trauma has to do with being in isolation in a room by yourself as opposed to being visited like in other diseases. So there are nuances of trauma that this disease has when you're in the hospital. And then there's a subset of people who get critically ill. But for me, when I frame my mind around that, of course, channeling that little bit of healthy anxiety that Dr. Glover mentioned, enough for me to say, did I take my mask? Do I make sure I'm not touching my eyes or my nose? Because this is how the virus will get in. If I go like this, pick my nose, my mouth, my eyes, or if I'm breathing in close distance to somebody. So that little bit of anxiety that makes me protect myself, I'm channeling. But when it starts to get to the point where I'm like, oh my God, I'm going to become like that patient or my family, my loved one, my kids, my husband, then I remind myself of the statistics and the data. And I say, you know what? Most people don't. And the other thing to put out for people, to the extent that it's helpful for people who are listening, is we're going to be okay. Whatever comes our way as a community, as humans, as people together, we're going to get through it. We're going to be okay. If it turns out that we're that few who gets really sick, it is what it is, and we're going to be okay. Those doctors in the hospital will treat you with love. The nurses will treat you with love and compassion. We will take the best care we can of you. For many of you, we'll get you out of that hospital. And for some of you, we won't. And we're going to do our best, and we're going to be okay.
Thank you so much. That was so informative. Dr. Glover has something to say.
So one thing that that has occurred to me, there's somebody who I follow on Instagram. She's an artist. Her name is Zenobia Bailey. And Zenobia Bailey often posts pictures of Black people in the 20s, the late 1800s, the early 20s, 30s. And I have been looking through her photos. And there are women in the Caribbean and women in Africa and women in the United States. And I think to myself, our ancestors got through the worldwide the flu pandemic in 1918, right? When I think that like there's no way we would be here if they didn't survive. So I know somewhere in our bodies is something that will enable us to probably make it. Our ancestors have seen it all. They've seen all the trauma, they've seen all the diseases, and somebody got us here. Somebody's mother, whose mother, whose mother, whose mother, and their father and father and father. So it is within us. So even though you may be overwhelmed with panic, that doesn't mean you're dying. That just means you probably have to work on your anxiety a little bit, maybe download the Calm app, download Headspace, learn how to meditate, learn how to breathe, but you will find your way through this because our ancestors did it all.
Thank you. That was deep. That touched my soul. Thank you so much for sharing that. We do have another question that since a majority of us are mad, like Megan was talking, how do we manage this disease at home? If we cannot go to the hospital, so we cannot get testing, what can we do at home to ensure that we're managing and we're not infecting our loved ones?
Hi, this is Lindana. So when it comes to managing at home, part of the key is the social distancing. And as I say that, I'm going to acknowledge that depending on your living situation, sometimes that is hard and near impossible. So we have to acknowledge that. So whether it's, wearing the mask, not sharing, things like glasses, and I'm touching my face, but trying to do what you can to sort of minimize transmission to your family members, even if, the living space makes it difficult, but just trying your best to do that. And again, when it comes to, symptoms, from a primary care perspective, I spent a lot of time being on the phone with patients, especially when things were, really bad. And a lot of times it really was symptom management. So for example, if you have a fever, we'd recommend, taking Tylenol, obviously not taking more than the recommended amount in one day, if that's just 4 grams in a day, but taking it around the clock to try to keep the fever, at bay. If you're having a cough, take a cough medicine, whether it's something you already have in your counter or you get in touch with your doctor and it's something that we can prescribe over the phone. If you're having shortness of breath, sometimes I would send, the asthma pump, the inhaler for patients to use, even if they don't have asthma, just to use it in that, space. So a lot of times it had to do with, being in touch with your primary care doctor, describing the symptoms that you had and trying to treat the symptoms either with something that you have at home or having your doctor, send something to the pharmacy. Then when I send something to the pharmacy, I would be in touch with that patient to say, hey, is there someone who's healthy and well who can go to the pharmacy for you or on your behalf? So that way, again, just thinking about the public and the health of other members of the public, everyone's meeting at the pharmacy in this public space, again, just trying to minimize transmission to other people. So those are some of the things in terms of managing symptoms that I spoke to my patients about.
Yeah, I think also, like you were saying, LaDonna, is taking advantage of the delivery services. My father, who was older and has some conditions, thought he was slick because he claimed that CVS wouldn't deliver his strips to him. They would deliver his medication. So again, it's like LaDonna said, saying, okay, have a family member who may be a little healthier, who may be a little bit younger to go to the store. I personally have not been in the supermarket in a month. I've been trying to stay out because as a healthcare provider who's in the hospital up to 4 days a week, I feel that I don't want to infect not only my family members and loved ones, but I don't want to infect the public. I don't think I've had COVID, thank goodness, but I still walk around again feeling like, okay, you know what? I've been exposed to COVID, so I'm gonna act like I have it. I go to the store for my family. I keep a distance. When I go there, I have a mask on. I don't stay very long. Just because it's my responsibility to keep them safe. And I live in an apartment building, so they put signs up, but even before that, I've been wearing a mask in my building because there's a lot of elderly people here. And unfortunately, my neighborhood is that deep red color where there's a lot of COVID. So I just try to do my responsibility as a citizen. And I hope that other people would take on that same responsibility of just trying to keep everyone, whether it's loved ones or people you don't know, safe.
Thank you, Allison. Thank you, Dr. Myers. That's very, very true. I do have a question that somebody asked reference, and we know that it's such a big thing out there, vaccines. Like, when will a vaccine become available, and what is our perspective on, taking a vaccine, or, will it ever become available, and how far out they say, like, I think previously it was like it takes 1 year to make a vaccine, but now some places are saying that it might be 4 months that we have the vaccine. So I might be quoting wrong, so I don't want to give false information right there. I see Allison's face is like, no, girl, that's not the truth. But anyway, could you please talk a little bit more about vaccination, and when do you think a vaccine will become available?
Hi, this is Lindana. So I'm just going to give you my primary care spiel on vaccination. So taking a vaccine is very much a personal choice. If it's flu season, I have to say, if you fall into an age category where you'd be high risk for influenza, if you're elderly and if you have, immunocompromised conditions, I do strongly promote the flu vaccine. When it comes to the, this vaccine that's being developed, historically, it takes years to develop a vaccine, right? It has to go from animals, then sort of trials in humans to make sure, one, that it's safe, and two, that it is effective. And so when you think about also the history of vaccines, if you think about things like measles, mumps, rubella, polio, these kinds of things in the past used to, kill populations, and now it doesn't. Why? Because we have, vaccines. And even at times, the luxury that people have now to choose to, not vaccinate their children really has to do with the fact that the majority of us actually have received the vaccine. And when we talk about herd immunity, the concept of herd immunity is that so many people in the population have the vaccine and won't get it, that it's okay if a small handful of people don't receive the vaccine, right? So I just want to put that in a certain context. The coronavirus vaccine that is working to be developed, and many, different organizations are working to develop it. And the idea is to try to develop this vaccine in a short span of time. And so, there is a question as to, what does that mean if in the past it takes years to develop a vaccine, and all of a sudden we're going to do it in a few months. And I think when we get there, we should definitely have a bigger conversation.
Definitely, we do not want to be spreading, false information. And I do agree. Taking the vaccine, probably shouldn't say that on the live, but I don't take the flu vaccine, but that's because of my like religious and cultural reasons that I don't take it. But I appreciate everyone else who is willing to take it just to protect and safeguard members of the wider community. There is a question about how long does the virus stay in the air, and whether it stays like it's passed on for like air conditioner, heating vents, and a blow dryer transmitting the virus. Is that even possible?
So I'll just offer something small. I'm definitely not an HVAC expert, but I know somebody brought that up at work, and the CEO of my entire health system, Dr. Philip Azua, he described that in most HVAC systems, especially in hospital settings and in clinics and things like that, there are filters built into the air systems, right, into the HVAC system to filter out viruses and bacteria. So I think we can proceed with some level of confidence that the virus is not going to be harbored in the air ventilation systems, assuming that the ventilation systems are good. There are case reports where particularly in call centers, right, these open office spaces where clusters of people got the virus because the air ventilation system by where they were sitting was not very good. So I think that's why a lot of businesses are reconsidering reopening, and they are having to be very thoughtful about reopening, because if their HVAC system isn't together, they will be responsible for the health of their employees. So they have to get themselves together. So that's also something that I think people have had to think about that maybe they never had to think about before.
Thank you. Does anyone else have any input as well? Okay, there is a question in the chat about, is it possible for keratolysis is it possible that keratolysis may be associated with COVID-19? I'm not too sure if I pronounced that word properly.
How do you spell it?
Hold on, let me see if I could get it back. I believe I lost it, so I would not be able to. Sorry, I lost it. Okay, so we're now running out of time. We have like 5 more minutes, and this was such an informative session. So thank you everyone for taking time out of your busy schedules, your quarantine schedules, and also for the people who are on the live. So before we leave, I wanted to know if there's any like lasting advice or information that individuals would like to share with the individuals on the live. Oh, and I have the spelling, it's KERATOLYSIS.
So I Googled it really quickly. It's a bacterial infection of the skin, and it can affect the palms and the hands. I haven't read anything or come into, like, I listen to a lot of medical podcasts on my way to work and from work, and so skin conditions as a cause of COVID, I have not heard any. It is primarily something that people inhale and something that people get when they are applying their fingers to their eyes or to their nose or their mouth. So I think hand washing should do it, and wearing your mask, if that's okay. And then for the other question about whether there's one more thing I would want to share, there's an app called Liberate, which is a meditation app that is specifically designed for Black and brown people. So I mentioned Headspace, I mentioned Calm, but if you want something culturally tailored to foster your own relaxation and anxiety management, check out the Liberate app. And I also sent along an anxiety workbook that hopefully you'll be able to send out.
Yes, we will be sending out in the chat. Thank you so much. Does anybody have any lasting words? Yes, Dr.
I just want to say, I think what Megan and Corinne were saying about hope is a wonderful thing, but I think we would be amiss by not acknowledging the fact that we have unfortunately lost people. And I know there are people that are actually watching and listening who have lost loved ones. So I don't want to take away from them. And I think we need to also say that it's okay to grieve. You know, I've had people tell me, especially with Mother's Day just passing last week, and I've had people say, you know, I don't feel right. You know, I'm trying to hang in there. You don't have to try to hang in. There's nothing wrong with crying. It's not a sign of weakness. It's actually a healthy, natural part of the grieving process. And, you know, you shouldn't feel any different than like what Mr. Roberts was describing about PTSD. Grieving is painful and can hurt. And if you're having issues, do not feel free. I mean, you should feel free to use the same resources that Dr. Glover was mentioning. And to all those who've been lost, may you rest in peace. And my condolences for all of you. And just stay as strong as you can.
And with that said, I would also like to say that I have many friends, like, you know, all of you who are in this chat room now, and you guys are on the front line. And as an IO psychologist, I know how important that it is for you guys to be able to manage your stress. And you have just kept going and going and going and going and going. So I want you to know, as Megan one time said in a meeting that we had, it's okay to pause, and it's okay for you guys yourselves to grieve, because you are seeing now death on a level that's unsurmountable, that you probably would have never ever imagined in your lifetime. So please take the time to be mindful, to be present, and to sometimes just cry. And it's okay to do that. Like, you do not have to be strong all the time, but we appreciate all the hard work that you guys are doing and putting your lives out at the front lines. And thank you, thank you, thank you, thank you so very, very much. But it's okay to grieve, and it's okay to be like, I know I'm going to be a doctor for the rest of my life, because this is traumatic. So it's fine.
Hi, this is Lindana. I think in terms of, you know, last words, again, from a primary care perspective, I think I agree definitely with pause, that coronavirus has forced us really as a society to pause and really to take stock of our lives. And I think everyone should use it as an opportunity just to think about, you know, whether it's trying to, you know, maintain connections or just trying to think moving forward, how we can sort of be more positive and be more impactful, whether it's, you know, with the relationships we have with our friends, with our families, with our colleagues. And I think, the other thing I think many people have been forced to do is to just have hard conversations about, you know, like life and death, whether it's about advance directives or, you know, getting a will. And these are really, really tough conversations to have, but I think it's very important. And so I would encourage everyone to just, you know, don't be shy about having those sort of conversations with your family, especially about sort of end of life wishes.
Thank you. Does anyone else have anything to say?
Well, as a civilian, I can say that I've seen I've heard a lot of my friends and stuff talking, and I can safely say people have grown up, because now people that we follow, like movie stars and artists that we follow, you know, there's nothing wrong to do that, but I can safely say a lot of my friends are talking, and our new heroes, and we are now groupies, quote unquote groupies, for doctors and health professionals now, because we can live without them, but we simply cannot live without our health professionals. That's all I got to say.
Thank you, Anthony.
You're welcome.
Anyone else with any lasting words? Okay, so we have 2 more minutes, and I'd like to take this 2 more minutes to thank everyone. This was so informative. I learned so much, and I'm pretty sure that the individuals on the live, they themselves also learned from this. And there are people asking for another session. So we do have one being planned for May 31st, but it will probably be a different set of individuals. And I noticed that there was so much information on like nutrition, like people wanted to know nutrition, and maybe it would be good to have a nutritionist and a dermatologist to talk about all of these issues. In addition, there will be a link that's sent out so that we could ask questions about how the Facebook Live was, and moving forward, like what information people would need to know. But as of now, people are saying in the chat that it's in a preview version. So I will be sending that out later after I figure out what's wrong with it. So thank you very much. This was very informative, and Janice would like to take a photo, so I'm going to end the live right about now so that we could take a group photo on Zoom.